For those that don't know me, my name's Ben. Sorry, I haven't got much of a voice, and you've all had to put up with me coughing in the back of the auditorium today. You're clearly all very bored to come here at this time. I'll do my best to keep you bored, but we'll be done in about 5 minutes. So up until recently, I've worked as a GP surgeon in Jamestown in the mid-north of South Australia. We're not allowed to use the term GP surgeon anymore. Surgeon is a protected term. So I'm now a rural generalist in surgery. GP surgeons and now rural generalists have been doing hernia repairs amongst other things for time immemorial. It's always been the assumption that we do a reasonable job. If you ask people what their driving ability is like, you're unlikely to meet someone who says that they're a bad driver. And yet, by definition, 50% are below the mean. And the College of Surgeons are pretty antsy about GPs doing surgery in general. And currently there is no literature anywhere in the world regarding non-specialist surgeons performing hernia procedures. So basically, I decided to do an audit of my own procedures, which is the way that a number of the rural surgeons present their data to the Provincial Surgeons Group, which is an annual meeting for the rural surgeons of Australia, including rural generalists. Not many of them attend. So basically, this is an audit of my data from 2007 until 2018, working in 4 small operating theatres in the mid-north of South Australia, 2 of which are now closed. During that time, I repaired 164 hernias, most of which were inguinal, but there was a reasonable number of umbilical and a couple of femoral and incisional hernias as well. The average age of people was 59, and the operating time for both was around about 40 minutes. Now, I've just included a couple of quotes from people that you won't know because they were my mentors when I went through my surgical training in Alice Springs. So, anyway, this doesn't fit. This is the problem from jumping from PDF to Word document, PowerPoint. Anyway, the information that I've included here, the rural college, the rural arm of the Royal College of Surgeons conducts a procedural audit tool for all of their surgeons, and I was able to obtain some data for 13 of their rural surgeons during a period of 2013-2014. So during that time they performed 465 procedures. So I've just made a comparison basically of my outcomes with 165 procedures to theirs. The aspects that the College of Surgeons are looking at are haematoma, chronic pain, hernia recurrence, and unplanned readmission, operation, and ICU admission, which is the figure down the bottom, which I think was 1 for them and none for myself. Probably because I don't have an ICU. Interestingly, our data, particularly with regards to post-operative pain and hernia recurrence, which are the most common procedures, our statistics are both below the sort of world literature figures. The numbers that I put in brackets for hematoma and postoperative pain relate to 3 patients that I was aware of who I know did not feature in the audit data for reasons I'll explain in a second. So officially my figures for both of those are 0, but I did have some other patients. And I guess for any of you that are interested in doing rural surgery at some point, I didn't appreciate this at the time, but I do now. So these were some of the issues that I had in terms of collecting the information. So firstly, in the principal hospital that I was operating, they somehow managed to lose their operating theatre logbook that contained nearly 6 years worth of patients. Even though that's an indefensible thing when it comes to a court issue, but there you go. I estimate that during that time there were 40 to 60 cases, of which, as I said, I'm aware of 2 patients with hematomas, one of which I had to re-operate on, and a second patient that had chronic pain. The small hospitals in which I worked basically had never considered the need for data collection. When I went through the records for the cases, well, firstly, the hospital refused to let me have access to the records despite the fact that I was the responsible admitting officer for each of the patients concerned, which was an interesting challenge. From the hospital records, I was unable to calculate the BMI for at least 94 patients, and we're also unable to establish the anaesthetic rating. It was fortunate, however, that for the majority of patients that I was unable to collect the BMI data from within the hospital because of the close working proximity of the hospital and the GPs in the area. I was able to get virtually all of that information from the local GPs. So just a couple of issues that happened at various times during that period in terms of changes in my procedures. Initially I started using a standard close weave mesh, but actually following listening to another rural surgeon presenting on this topic a few years back, I started using a lightweight mesh, and I suspect that that's had a little bit to do with my reasonably low chronic pain issues. The use of a TAP procedure for local anaesthetic post-operatively, and more recently I've been using a pre-peritoneal mesh procedure called a Kugel repair for either recurrence or in patients where I was having likely to perform a bilateral procedure, particularly in situations where previously I felt obliged to send most of my bilateral procedures away to a more regional centre, as there was arguments about whether or not to do an open procedure versus a laparoscopic procedure for those patients. So I'm racing through this fairly quickly, but basically you never know when someone's likely to do a retrospective study and how far back that's going to go. I was really impressed, about the quality of the information that we were collecting in our facilities, but it was probably a measure of the fact that most small hospitals in our area are running on shoestrings pretty well, and are not anticipating being centres of study or research. But I think we all have an opportunity to do that. A couple of years ago, I was at a talk where the head of a tertiary surgical unit in Adelaide basically described the options that he gave to all of his heads of department and said, what do you want to measure? Hospitals have been very good at using proxy measures for deciding what are good things and what are bad things, like length of stay, something easy to measure because we know when people were admitted and when people were discharged. But that may not necessarily be the thing that you need to know. So understanding the sorts of things that are important in the things that you're doing and what sort of things you want to follow up, just in case, even if you end up deciding not to do that. It also gives the opportunity for other people, if they do happen to review your work, to be able to clearly see what's going on. And to that end, to set up the parameters in advance. And that's basically it. So, any questions? Sorry, firstly, I would encourage anyone that does these procedures to try and audit their data so that we've got more information. I work on the working group towards a new surgical curriculum for ACRM, which we've recently implemented, and part of that has been a discussion with the College of Surgeons about their stamp of approval and, more importantly, about potential towards developing this into a diploma, which is co-branded with them and the College of GPs. One of the arguments that the College of Surgeons have had against us is that they've said that we're not fair dinkum, and really we've had no evidence to be able to argue that point. And so if you are doing this work or any other surgical work, Mickey Mouse trials like this are what we need, at least to get us started. So I'd really encourage people to do it.
What is your length of stay? What's your post-operative length of stay?
So I haven't got it. I have got the data. The majority of them went home the next day, which is a different behaviour pattern to what they do in a tertiary centre where they're kicking people out. I was fortunate to work in a centre where we really had probably 30% occupancy, and I had the luxury of keeping people in overnight. Patients had further to travel for their procedure. It was far easier to keep them in, make sure that everything's okay.
What about pain management?
Post-operative pain management was basically local anaesthetic perioperatively, and then they were basically immediately started on regular, usually Voltaren, paracetamol and Indone, but most of them just went home with Voltaren and paracetamol. Yep. I'm really keen to do this. I have had a look at a couple of other procedures I do. I used to do cholecystectomies, and I've ceased doing that, but I have done an audit of that as well. I think the more information we get, the stronger our case will be. And there are plenty of procedures that we could audit. Carpal tunnels, vasectomies, they all seem like that it's obvious that we should be doing these sort of things if we've been trained, but again, we don't have the evidence to support that. And it's very easy to collect, but we just got to think about it before we do it. And I think that's where the difficulty was here, that we're just doing the business most of the time rather than worrying about the science, where if you go to a tertiary centre where people are perhaps less busy on those sort of things, people are thinking about what little research project can we do. We've never been thinking about that. Yeah. Sorry, did you apologise for that? The issue that I've observed both within South Australia and nationally is that if a service is closed, it will never reopen. So one of the things that we need to do is plug the gaps. When I moved to Jamestown, which is where most of this information is from, I basically replaced a exiting GP surgeon. If I hadn't been there, that service would have closed a number of years ago. I've left a bit of a gap there at the moment, but if there's somebody else to move into that, that'll be a long-term viable option for people. There are still plenty of options, and I think if you look at the rural generalist movement that Paul Worley's working on, there's certainly a very strong argument for having someone that has a smaller range of uncomplicated procedures that they can do safely. And internationally, any procedure less than a gallbladder is considered not subject to small volume. Like if you work in a small volume unit like I do, you're not subject to loss of skill. If you do more complicated procedures like bowel repair and so on, then you obviously are. But they're suggesting that for gallbladders and less, then once you've acquired the skills, it's like riding a bike. Yeah. For my audit, I was so technical, I just got the logbook out and looked up the word hernia. Basically, I had access to all of that apart from the 6 years of missing data. The College of Surgeons do have a procedural audit that they do for a range of procedures, including hernia, and they do offer that as an option for anybody that's doing it, but I understand that it's quite expensive to enrol into, but it is offered. Yeah. So if you're looking at doing it from that point of view, you probably need to get your hospital to support that. Yeah. Yes. So I had the good fortune of attending a rural, well, it would be the Canada's equivalent of the GP surgeon. They call it an ESS, but they have a conference once every 2 years. So I attended that earlier this year. Was lucky enough to meet a number of people there that are been the people providing a huge impetus for change over there. So they've got their rural generalist project up and running successfully now, but it's essentially limited to British Columbia and Ontario. They still don't have any outcome data. So I was talking to them about this particular issue. They are actually looking into it as well, with the intent that between us we can further solidify the argument. Yeah. Run out of questions. Thank you.